Welcome to our deep dive into the long head of the biceps LHB at the shoulder. This video explores the latest findings from a comprehensive scoping review, aiming to clarify the anatomy, function, pathology assessment, and management of the LHB. The LHB's role at the shoulder has long been debated, with its contribution to joint stability and movement still not fully understood. Through a systematic review of over 200 studies, researchers have synthesized key themes and identified knowledge gaps that are crucial for clinicians, researchers, and anyone interested in musculoskeletal health. Let's begin by setting the stage for why the LHB matters. Main goal of this scoping review was to update our understanding of the LHB at the shoulder. Researchers wanted to explore the extent of available literature, synthesize findings into emergent themes, and highlight knowledge gaps that could inform future research and clinical practice. By systematically searching multiple databases and including studies on adults, the review aimed to provide a comprehensive overview of the LHB's anatomy, function, pathology, assessment, and management. This approach ensures that the findings are both reliable and relevant for guiding future directions in shoulder care. Anatomy of the LHB is more variable than many realize. While the typical origin is from the supraglenoid tubercle and superior labrum, studies have found numerous variations including aberrant origins, extra accessory heads, and even congenital absence of the tendon. These anatomical differences are not always harmless. Many are associated with shoulder pain and instability. For example, aberrant origins and absence of the LHB have been linked to increased reports of pain and joint instability. Understanding these variations is essential for accurate diagnosis and effective management of shoulder conditions. Functional role of the LHB at the shoulder remains a topic of debate. In healthy shoulders, evidence suggests that the LHB plays only a minimal role in shoulder elevation and stability. However, in cases where the rotator cuff is damaged or absent, the LHB appears to take on a more significant role, helping to stabilize the joint and depress the humeral head. This compensatory function becomes especially important in pathological shoulders, where other stabilizing structures are compromised. The review highlights the need for further research to clarify the LHB's exact contributions in both healthy and injured shoulders. There's a well-established association between LHB tendinopathy and rotator cuff disease. The review found that LHB pathology often coexists with rotator cuff tears, instability, and other shoulder problems. In patients with rotator cuff tears, the LHB may become hyperactive, possibly as a compensatory mechanism. However, the exact cause and effect relationship between LHB pathology and rotator cuff disease remains unclear. Does the LHB become pathological because it is compensating for a torn rotator cuff, or is it a secondary effect of broader shoulder degeneration? More research is needed to answer these questions. Assessing LHB pathology is challenging. The review found that traditional orthopedic special tests and palpation have limited diagnostic value for LHB-related shoulder pain. While clusters of tests and the use of imaging such as MRI and ultrasound can improve diagnostic accuracy, there are still significant limitations. For instance, arthroscopy, often considered the gold standard, may not fully visualize the proximal LHB, potentially underestimating pathology. Clinicians must be aware of these limitations and use a combination of clinical judgment and imaging to make informed decisions. Imaging plays a crucial role in diagnosing LHB pathology. The review found that both MRI and magnetic resonance arthrography (MRA) have high specificity for detecting full-thickness LHB tears, but their sensitivity for partial tears is lower. Diagnostic ultrasound is also effective, especially for identifying dislocations and full-thickness tears, but less so for partial tears and tendinitis. The choice of imaging should be tailored to the clinical scenario, and clinicians should be aware of each modality's strengths and weaknesses. Surgical management of LHB pathology is under-researched. The review found limited evidence supporting conservative treatments like physical therapy, dry needling, and exercise. Image-guided injections into the bicep sheath provide better accuracy and outcomes than blind injections, but there are risks, such as unwanted spread of medication into the joint. Overall, more research is needed to develop and validate effective rehabilitation protocols for LHB-related shoulder pain. Vertical options for LHB pathology include tenodesis and tenotomy. The review found that both procedures offer similar improvements in pain and function, with no significant differences in strength outcomes. However, tenodesis is associated with a lower risk of Popeye deformity and cramping arm pain, while tenotomy tends to be more cost and time effective. The choice between procedures should be individualized based on patient factors and preferences. Patients with rotator cuff tears, but a healthy LHB, adding tenodesis or tenotomy during rotator cuff repair, does not provide additional clinical benefits. The review suggests that routine removal or surgical alteration of the LHB in these cases should be avoided, as outcomes are similar to rotator cuff repair alone. This finding challenges the trend of routinely including LHB surgery in rotator cuff repairs, and highlights the need for more selective surgical decision-making. Review found that certain complications, such as Popeye deformity and cramping arm pain, are more common after tenotomy, especially in younger male patients. Patient satisfaction may also be lower in this group. These findings underscore the importance of considering individual patient characteristics, such as age, gender, and activity level, when choosing the most appropriate surgical intervention for LHB pathology. Despite the breadth of research, significant knowledge gaps remain. The exact functional role of the LHB in shoulder stability, especially in asymptomatic rotator cuff tears, is still unclear. There is also a lack of high-quality studies on non-surgical rehabilitation protocols and the long-term effects of routine LHB removal during rotator cuff repair. Addressing these gaps will require well-designed clinical trials and further basic science research. Based on current evidence, clinicians should be cautious in diagnosing and managing LHB-related shoulder pain. A combination of clinical assessment and imaging is recommended, with awareness of each method's limitations. Non-surgical management should be considered first, especially in the absence of severe pathology. When surgery is indicated, the choice between tenodesis and tenotomy should be tailored to the patient, considering potential complications and individual preferences. It's important to note the limitations of this scoping review. Only English-language studies were included, and gray literature was excluded. The methodological quality of included studies was not critically appraised, and there may be a bias toward rotator cuff pathology in the literature. These factors should be considered when interpreting the findings and applying them to clinical practice. Summary: the long head of the biceps at the shoulder is a complex structure with variable anatomy and function. Its role in shoulder stability is minimal in healthy individuals, but may become more important in the presence of rotator cuff pathology. Diagnosis and management remain challenging, with both non-surgical and surgical options having their place. Clinicians should stay updated on emerging evidence and tailor their approach to each patient. Continued research will help fill existing knowledge gaps and improve outcomes for those with LHB-related shoulder pain.